discovered that ultrasound actually could be used to look at the heart. But by the way, I am sure no one in this hall today is having any engineering background. Anyone has any clue why ultrasound was first used ever? Anyone has any clue? Very good, excellent, very good. You are very light. So it was first discovered to measure the depth in the ocean. And in the you go to your morning walk, you go for your rounds, and rather than using stethoscope and examination, you start using ultrasound, and that machine will give you some information, and that is your newest tool. But then this part I found is very interesting. Someone feels that if you are full, even with a stethoscope, you will be full with an ultrasound. And very true, we have to always use any information you find, you have to use it only with your judgment. But then very fast we are moving from a stethoscope to ultrasound, and now we are having MRI at the bedside. It's very difficult to consider that MRI could be used on a bedside, but some hospitals started using a mobile. You can use that. This MRI has a wheelchair, as a chair, and it could be brought to the patient's bedside. It's not easy, and you will be very, very delighted to see that sometimes it looks like a very clear picture, and you may not need to do an echocardiogram, and MRI will give a picture. And again, I'm talking too fast, but you can see that multiple different abnormalities could be diagnosed, and there is the two ventricles as a common outlet. It's like a double outlet right ventricle, or this aorta may be very small, or the left ventricle may be very thick, like a hypertrophic cardiomyopathy type, and this left ventricle is very small. So MRI obviously could be very, very easy. So now if we move from there, let's go back to that how much we have done and how much we have progressed in the last 2 decades in fetal echocardiography. It is still difficult, I must say. So, but still, if we think that what are the possibilities, imagine in your mind that this is the head, and this is the chest, and this is the tummy, and this is all within mom's womb, and then you are trying to get the very first picture. You are trying to go across the abdomen, and then you are getting a picture where spine is at the back, and this is our anterior part, and this is stomach, and this is within liver, the portal system. And then just from there, if we go a little up, there start our fourth chamber, and you identify these structures. I don't have to go each time about which structure is which. And then you can go through there. This is the first ventricle, is the right ventricle on the top, right and left, atrial ventricle. Just going further angled towards the head, little cranial angulation, our first outflow tract comes, then the outflow tract, and then if you go further up, right ventricle outflow tract comes, and then 3 vessels we see. We'll talk several times today, SVC, aorta and pulmonary artery. And remember this, we'll have a little bit of question coming there in my slides. As you see the 3 vessels, very much you can call them magic. If you go from right to left, SVC, aorta and PA. If you go from anterior to posterior, again, pulmonary artery, aorta and SVC. But also look at the relative size. SVC is the smallest, aorta is a bit bigger, definitely bigger than SVC. But in fetal life, our pulmonary artery is a little bigger than aorta. So by each of these, we will diagnose many conditions. As you see, first we need to get the pictures right, and then we'll try to get the diagnosis with each of these. And we'll have enough pictures to talk abnormality of 4th chamber, abnormality of outflow tract, abnormality in 3 vessel, or in their relative size, or which vessel is first branching. Is the pulmonary artery anterior, or another vessel comes anterior? And finally, as you go further up, this is those who are very new in the fetal medicine. Ductal arch is a fetal structure which we do not have in our life. Once we are born, we do not have our ductus, which is present only in fetal life. And these are the 2 arches as you talked about. These are the ductal and the aortic arch, and you see this big confluence. This is a very important landmark for us. Firstly, they are quite proportionate, and they meet on the left side. So as we talked about, this is the left side all through, this is the right side all through, this is anterior, posterior, everywhere. So every time we'll try to remember in our acquisition of pictures, if we go from the abdomen towards the fetal head, starting from port chamber, and then we talk about 5 chamber, and then we get 3 vessel view, we get SVC aorta pulmonary artery, and we remember that big confluence. So I'll try to go through each of these, and we'll try to go normal and abnormal pretty quickly. Today, as we have a separate talk on port chamber, I'll try to skip the port chamber, and then we move to the rest of the pictures. Okay. So let's see how this moves. So what we need to do, that we have to keep the head of the fetus to the right side of the screen. When we keep the head to the right side of the screen, then we have to take the probe just simply clockwise, turn, and then we want to get a short axis cut or axial cut of the whole chest, preferably with one rib. I'll let it run once more, and then you get a sense of that as if our head is on the right side of the screen, and then we get a turn to make a cross section of the chest, and there we get a 4 chamber. We have better pictures. This one is not so clear, I know. From the back of this hall you may not see it so well. But just again, to go into this 4 chamber view, we will very fast move from a normal to abnormal. Okay. So let's move this one. Some of this I intentionally tried to put some sketch so that it becomes much easy for you to understand. As we talked about the previous screen, that we talked the right ventricle, left ventricle, the atria, and then left ventricle leads to left ventricle outflow tract. So very easy to see, and some of the things you may be surprised that how in a fetus the pictures could be so well. And of course, again, as I mentioned, we have to be lucky. And again, I am very aware that you do not do routine ultrasound on a day-to-day basis, but very simple technique we want to go through whenever you use any form of ultrasound, 2-dimensional or 2D echo, followed by the color. Thank you for reducing the light. I think as this is the life of a pediatric cardiologist and adult cardiologist as well, we often try and spend our life in the darkness, otherwise pictures are not very good. So you can see the 2D, as you put a color, a very nice laminar flow through the left ventricular outflow tract. So this is our left atrium, these are the pulmonary vein, and this is aorta here, descending aorta, spine, as you go through, and a very nice color Doppler pattern. I'll not go through how much of the scale here for this audience. It is more important for the technologists, but this is very important to know that optimize the angle, optimize the color scale. Anyway, let's keep those things. I think let's keep it easy, and so that you can move through some of the basic idea about the fetal echocardiogram rather than each nitty-gritty. And as you have seen the left ventricular outflow tract, you have to see the right ventricular outflow tract as well. So this is a good view of the right ventricular outflow tract, as you said earlier. So right ventricle, pulmonary valve, right ventricular rest of the pulmonary artery, and it leads to the ductal arch. This is right pulmonary artery. This is the left side. You know the pulmonary artery actually is the left side, right? Then aorta here, and then this portion here is we are seeing a portion of the right atrium. So we get to see the valve quite well, and we even comment quite often the dysplastic pulmonary valve or dysplastic aortic valve, and we may see a flow acceleration in the aorta, pulmonary flow acceleration also we can see as well. So these are not actually that difficult when you are lucky to get good pictures. And just as we are mentioning, we go through 2D color and same 2D color, and you get very nice pictures of right ventricular outflow tract going through the pulmonary valve and right pulmonary artery, and aorta is next to that, and the right pulmonary artery goes just behind the ascending aorta, and the rest of the pulmonary artery. Here I could not show the left pulmonary artery, and left pulmonary is little difficult to see as it is overlapped by this is the ductus. Again, we are repeating that ductus arteriosus is a normal structure in fetal life, and which is actually as big as the aortic arch. And ductal arch is the inferior arch, comes from the anterior ventricle or the right ventricle, and the aortic arch we'll be seeing in a minute. Sometimes again I use make life easy for everyone, the same picture, but now we are showing trachea. So trachea is not that easy to see, but when we put some color for easy understanding, SVC, aorta, pulmonary artery, you see the relative position of them going from again right side to left side, smaller SVC, bigger aorta, pulmonary is even bigger, and trachea is just behind. We'll try to identify each of these structures as much as we can, so it helps us to find out whether there are any abnormality of the three vessel view. So three vessel is our friend, and this three vessel we like to see different. Each of these, they are present in oblique line, and we talk about from right to left, and then posterior to anterior in relation to trachea. And any time if you notice that this one is either in the size of SVC, it is abnormal, or if we see that aorta is bigger than pulmonary artery, then either of this is abnormal. And rarely we may see a left-sided superior vena cava as well. But remember also this arch, the ductal arch, and if we go a little higher, we'll come in next slide, this arch needs to move to the left of the midline or left of the trachea. That's normal, as the aortic arch also should be left. It should not be on the right side of the body. Then we call it a right aortic arch, but which is abnormal, right? Okay. So still we are talking normal, normal, normal. So we are going through pulmonary artery, dividing to right pulmonary artery, and this time it is left pulmonary artery, as it comes from the main pulmonary artery, and the rest is ductal arch. This is my descending aorta. So just to give you the orientation, posterior and anterior, this part is the ribs and the sternum, and this part is the spine here, and descending aorta is just left of the spine. All good? Should I go slow, or I think everyone is understanding? I don't want to lose anyone anytime, as because now the abnormal pictures are coming. Okay, so you have to identify and diagnose. Okay, so still normal. We talked about three vessel view, three vessel trachea view. So just now as I was mentioning, here it is the trachea. So your ductal arch, aortic arch, but left of the midline. This is midline, and then right, this is the left of the midline. So aortic arch is normally left aortic arch. Sometimes aortic arch could be right. So think about that. As I mentioned, forget about the scale of the Dopplers when we are producing color. When you will do hands-on pictures, then it is very important how to improve your image quality, but leave it now. Okay. Just I miss this part, just remember that any time any reversal of flow there is, again, a quick question. You guys are doing very well, especially our younger students. Any of you in astrophysics, anything ever thought about? No? The reason I'm saying that my probe is there, that's why it is blue color, okay? Probe is here, any blood going to the probe will be red color, any blood flow going away from the probe is blue color, okay? Probe is here, so the ductal arch, aortic arch, they are blue color. SVC blood is going towards the probe, so it is red color. So if you do not ever go through the astrophysics, the reason I was talking, we know that a solar system which is actually moving away from our galaxy, moving from our solar system, then it is red color. Anyway, not to confuse, anything coming to my probe will be red, the SVC, anything going away from my probe is the blue. That is normal. If by chance, again we have pictures where we will see that there is reverse flow abnormal. The V confluence not seen abnormal. Any of them are proportional, disproportionate abnormal, and then this one is not coming to the left side, is abnormal. Okay, so now look at this right picture. This is the time, already I have given the diagnosis, but look at this, trachea is in the midline, and what we are talking, SVC, aorta, pulmonary artery, the ductal arch, trachea is in the middle. So what is happening for the aortic arch? it is on the right side of the midline. So that is right aortic arch, and that is abnormal. I will not go through much of this. I know you guys study a lot. We published actually papers on vascular rings and slings, and any of you have any interest, what does it mean? In today's talk, I think we don't have enough time to talk about the rings and slings, but any blood vessel which is going on the other side of the airways or midline of trachea and esophagus, it may cause compression of the airways and the esophagus, and that's called vascular rings. And there are slings, which actually is very, very relevant for us, and we published recently one of our actually interesting study story when you think about our first author is not a med student who published anyway. In Canada, we work in a very different way. He was an aspirant of med school, but he couldn't make it. But he actually worked with me, and we published that paper. So, rings and slings, as you are talking, and those who have interest, please go through. That paper is a very simple paper. We are not talking anything complex there. Okay, next question. Stay tuned. Kindly look at this picture. Now I want all of you to give me the diagnosis as in the last few slides. Whatever we talked about, I'm talking again. Anterior, posterior spine is here, and these three vessels, SVC, aorta, pulmonary artery, and something rings the bell here. The aorta and SVC size look almost similar. So what does that mean? Now I'll go slow as I'll give you time to think about. Firstly, just say, is it normal or abnormal? Abnormal. Why it is abnormal? Just say what I said to you now. Why it is abnormal? Aorta size is not bigger than SVC. So what are the two? When you compare with two structures or two hands, and if you see they are asymmetric, so either one is smaller, other is bigger. So what is the problem here, you think? SVC is bigger or aorta is smaller? Could be SVC smaller. SVC smaller, chance is much less, just so you know. If you don't know, SVC smaller, chance is very, very less. There is one question where SVC could be less. If there is a left-sided superior vena cava, I know you don't see that quite often. Left-sided superior vena cava is not rare for us. So quite often children are born with a left-sided superior vena cava. It's not a concern, just because that there is a left-sided superior vena cava. Anyway, let's come to the point. The other possibilities, aorta could be small. Okay, let's look at this. What we learned before, these two arches should be similar. What does it look like? This is ductal arch, this is aortic arch. They're still flowing forward, but this one looks much smaller than the ductal arch as well. So it is not only the SVC aorta when you compare, but when you compare with pulmonary artery aorta in a normal picture, what do you say? They look similar, almost similar. But what we see here, aorta, aortic arch looks small. Now again I'll go slow. This is the four-chamber heart. This is the left atrium, left ventricle, ventricular septum, right atrium and right ventricle.
Light नहीं चल रहा है ना.
I didn't show much of four-chamber, but what does it look here? This should be almost similar. How does it look like? This is right side and this is left side. The right side looks similar to left side. Very large. So left side is small, again same thing. Either right big or left small. So far what we see, SBC, aorta, PA comparison, aorta looks same as SBC but smaller than PA. Means aorta small, aortic arch small, left side small. Then what do you think? So significant. This is a term we often use, significant left to right discrepancy. Another opportunity for you to show up and rise and shine. Anyone wants to see. If you want to go to diagnosis direct, I'm happy. But otherwise, can you describe this structure? This is aortic arch. These are the head and neck vessels. This is the ascending aorta coming there. Anyone has any clue what is going on here? Aortic aortic arch. I haven't shown many pictures of aortic arch before, but that's the test. This is the aortic arch, which looks pretty small, and that is coarctation of aorta. So we diagnose coarctation of aorta in fetal life, and this is very, very important. As you were talking through some of the works we have done over years, how we can optimize the delivery of a mom who is carrying a child with congenital heart disease, where we want to give them the best chance of survival, best chance of surgery, and for that, the doctors introduce us with fetal structure. You may keep it open, you may need to keep it open afterward if such a problem is there, and one of the commonest is coarctation, and because otherwise baby would be in significant problem when the ductus arteriosus closes, and that may be needed for this baby's survival. So once we diagnose coarctation of aorta, we have to always be careful that this is a baby who may need prostaglandin to keep the duct open. I'm very happy to take any questions if any of you feel like it is too much for you. You want me to? Yes, please go ahead.
How to identify, is it preductal coarctation or postductal?
Sorry, say that again.
How to identify whether it is a preductal coarctation or postductal?
Okay, so these are like, this reminds me of my med school days. I think, to be very honest, you don't need to think about that. Most coarctations in neonatal life is just a duct. So we are smarter than med students, so we don't say pre or post, we say just a duct. So most of the times they are just a ductal. Extremely rarely, coarctation is postductal in neonatal life. Or in other words, almost all the time. If you see you have seen 1,000 coarctation in one patient, you may find that the prostaglandin did not help the baby. If any of you manage patient, I don't know any of you manage coarctation, anytime there is a question of coarctation of baby having problem, stop prostaglandin. There is no exception, there is no problem, there is no contraindication, stop prostaglandin. So answer to your question is, you are asked for a reason, but the answer to that is, this is not time to think about where is the coarctation, is it there, is prostaglandin going to help? Uniformly prostaglandin will help these patients when there is a coarctation. And we have used coarctation, or rather, not only we have used, we routinely use prostaglandin even in a 3-week-old baby, when the duct is closed, we cannot see duct, still use prostaglandin. And the reason being, as this part, a little bit constriction, even if the duct doesn't open, it may ease out, smoothen a portion, even a fraction of millimeter arch may be open just by giving prostaglandin, even if duct doesn't open. Anyway, I'm answering to your question in a difficult way, as because when you manage patient, don't worry about pre or post, always start prostaglandin and it will be very, very helpful. Okay, moving now back to normal again. So now, head, and this is our cartoon pictures of this, of the aortic arch. Head and neck vessels come from there, and then aortic arch, as you say, is the posterior arch, anterior part will be the ductal arch. If we overlap, we'll show that a few times. Ductal arch comes from there, but comes below the aortic arch. Aortic arch comes from the posterior, but goes superior. So aortic arch is superior, but posterior. Ductal arch is anterior, but inferior. And there, and those who are in golf, of course, you may equate that, but this is being described as a hockey stick as opposed to the arch. So that's the difference. The ductal arch is being described as a hockey stick-like structure, which is more straight, and this one is more curved. Again, not easy. When you start having the probe in your hand, and you find the difficulty of identifying which arch you are dealing with. Okay. As this is related to port chamber, so I'll leave this, and then once the port chamber is done, but actually the port chamber is there, so let's keep those. These are not obviously hard pictures. Those are doing ultrasound. This is brain and this is circle of Willis, and I have few more pictures of this is important for cardiologists, the circle of Willis and the middle cerebral artery and the flow pattern we talk about. We will have some things just to think about. Now you all identified this one is mainly ductal arch. The head and neck vessel is not coming from this vessel. That's the problem in imaging, and aortic arch is on the top of it. Anyone can identify now the red flow. I said before, here is my probe, so the blood going towards my probe is red, coming away from my probe is blue. So what is this red flow? This is all within the heart. Another normal fetal structures. This is not present after birth. So this is inferior vena cava going through there and going from this to this way. This is foramen oval. This is the ductus venosus taking blood from the mom. Nature is so smart that the blue blood, which is going through the IVC, but the ductus venosus, through its intricate mechanism, increases the velocity of the ductus venosus to take the maternal oxygenated blood to the heart. So we see that PFO is a normal structure, foramen oval is a normal structure, which we need actually, and restriction of foramen oval is not good for the baby. This one is difficult, but anyone wants to answer. This is in the ventricle, we're doing in a cross section. This is abnormal heart. This is atrioventricular septal defect. Then there should be a septum here. There is no septum. This is the left component of the AV valve. This is right component of the AV valve. Okay, so the difficult one. This is for the radiologist, just for a distraction. This is not a fetal study, fetal imaging. This is a catheter. And anyone wants to volunteer? This is SBC coming from here, right pulmonary artery and left pulmonary artery. Anyone knows what is it? This is this is a Klein operation. You know, in a single ventricle we connect the SBC to pulmonary arteries. This is a Klein surgery after second stage of single ventricle. Anyway, okay, so this one I would request you to go through again slowly. In our three vessel view, we talked about SBC, aorta, and pulmonary artery. What do we see here? This is the middle vessel, which is branching into branch pulmonary arteries. So SBC, aorta, pulmonary artery, but the artery which is dividing into the branch pulmonary arteries in the middle. Transposition. Excellent. So we diagnose transposition, which is unfortunately one of the difficult one in fetal life. If you diagnose transposition, it's very, very important. Management is very important. Transposition patients may be very sick soon after, and you may know that balloon tract septostome is very important. Anyway, okay. Who wants to diagnose this one? Okay. Now I'll go slow. Please look at it, and this one I'll wait for you to give me a diagnosis. Okay. I'll show you. This is left ventricle, right ventricle, ventricular septum, and I said our probe is here, so that's why blue blood is going. But what is happening here? Few findings, little findings, but easy finding. You want to try? PhD. Along with PhD, what else is going on? Very good. I just am saying that this is, if this is aorta, it arising from both ventricles. So it may be single, at this moment we don't know, but at least we see a big outlet which is going from both ventricles. So PhD and then aorta going on the top of both arteries. Okay, so see, this is a still frame of this one again, left ventricle, ventricular septum, right ventricle, same patient, and then ventricular septal defect, and aorta is arising from both ventricles. Now watch the next one. So what we see here is, watch, sorry, what? This one is not running, this should be running actually, I don't know. Anyway, this is the aortic arch and this is the ductal arch. So in which condition you have a VSD with overriding of the aorta, and so aorta is bigger, as you see here. The pulmonary artery is actually smaller. It's not that small, but pulmonary is small. So it's a tetralogy of Fallot. It's a tetralogy of Fallot. Sorry, this one is not running for a reason. And as we talked about optimizing delivery sites, again, this is very, very important. If we know a patient with tetralogy, it also could be duct dependent. So you should be very much paying attention that this patient should not be delivering in a small hospital where you don't have the facilities of managing the patient with a cyanotic heart disease. Okay, so this one diagnosis is given. All of us agree. In the previous pictures, we talked about the ventricle to the aorta, ventricle to pulmonary artery. They were crossing. So when it is from this ventricle, the structure, the outlet would go this way, and when it is from this structure, it would come this way. This is parallel vessels. It's a transposition of great arteries, either before birth or after birth. And then this transposition can be from this view in same way. What I was telling before, the arch which is posterior coming from the ventricle goes superior normally, and the arch which comes from the anterior ventricle, that is the ductal arch, which goes inferiorly. But here, the arch, the ductal arch, which we are thinking, so it is not the ductal arch. So from the anterior ventricle, the arch which comes also superior. So this anterior arch also goes superior, and that's the diagnosis is transposition. So just to go back, the different views, they could be parallel, and then they could be, in a way, the anterior ventricle gives rise to the aortic arch. There is no obstruction here, but in transposition, even if the blood there is no obstruction, actually they would be quite serious. Just showing some more complex anatomy, double outlet right ventricle is a very large VSD, and then we see the pulmonary artery is rather very small. We don't see this. I don't know how many of you guys in med school you learned about aortic mitral continuity and discontinuity. Normally our mitral valve, which is here, and the aorta actually is continuous, but here it is quite far away from the mitral valve, and we call it an aortico-mitral discontinuity or aortic valve mitral valve discontinuity. I am going through the last complex patients, so go slow. Right and left ventricle, right and left atrium. Any of you know coronary sinus? Coronary sinus is a structure, is a normal venous structure, which is going behind our left atrium, but in this patient is very dilated. And the commonest cause of coronary sinus dilatation is the left superior vena cava, which can be associated with some abnormality, though by itself is not abnormal. But did you notice, I intentionally put it, I didn't keep it for any kind of your diagnosing, but I write it here. The pulmonary vein, right pulmonary vein tends to right atrium, left pulmonary vein tends to left atrium. So abnormal, this one is abnormal, and this structure is azagus vein, which is present on the right side of the aorta, very large, which is abnormal. Now the question, anyone knows why azagus vein is there so large in this patient? It's interrupted IVC. It's a condition where inferior vena cava is actually interrupted at the IVC level, and so the azagus vein takes over and takes the blood from below up. In If the IVC, as it goes from there, IVC is interrupted, then blood has to go by the side of that, and azagus vein or hemiazagus vein, they start taking blood from there. Just same one, I have put color here. The right pulmonary vein goes to right atrium abnormally. The azagus vein, their spine here, anterior and posterior. And so the patient has multiple abnormalities. And I will not ask you the question, but this type of abnormality, when we see, it is usually isomerism. Isomerism, I don't want to discuss until anyone has any question on this. So let's move. So the same one we wanted to talk, this azagus vein or hemiazagus vein behind the aorta is a large prominent structure when our IVC is interrupted. Okay. Moving completely. One or two signs I will show. This patient in this way having a large ventricular connection, and actually whole atria, left and right side, is almost like a common. And this patient has an AVSD, and we call this in the center of the atrium, otherwise no septum at all, and we call it a dot sign, which these are all hallmarks of isomerism. Basically, isomerism means when you see, look at us, our both hands are as if symmetric, as if we can divide the body into two halves. But think immediately, our chest, we cannot make the heart into two parts. We cannot make our abdomen into two parts. We have one liver, one spleen, one splenic flexion, one stomach. So they should not be equitable. They should not be bilateral. In isomerism, that happens, and it gives significant abnormality, and almost always there are enough problem in the heart. So that is one of the conditions, and they can have multiple other issues as well, including bowel obstruction, splenic dysfunction, and problem in the lungs as well. So that we can diagnose in fetal echo quite well. Any questions, anything before I move? I know I'm talking many things. It is very difficult when we move to many complex topics of congenital heart disease in fetal life. But anyone wants to have any question, please go through. And I'm very happy to take questions on any. Okay. So quickly moving beyond, little bit beyond the heart, the blood vessels around the heart. And this is a structure, just to remind, we talked today about few structures which are present only during fetal life, like ductus arteriosus, like foramen ovale. And this is the other structures we talked just now. We introduced the concept of maternal blood coming through the umbilical vein, going through this very intricate structure of ductus venosus. This is ductus venosus, which has the highest velocity in fetal life amongst the veins. So as because any of you ever watered your lawn with a garden hose, if you pinch it or you play it, it goes at a higher velocity. Now I have to ask you, you said that you don't have interest in astrophysics. Any of you have any interest in oceanology? Any of you ever know that when water moves in the ocean, they sometimes move in one direction, even there is no barrier in between, no reefs. So that's why water flows always in one direction, and that is due to relative difference in the speed of the way water is going. Same analogy in our body, and this is important in ductus venosus, that the most oxygenated blood coming from the mom through the ductus venosus doesn't mix with the venous blood coming through the IVC. And because it has the highest, very high velocity, it straight grows through that right atrium, through the foramen ovale to the left atrium, and then body started getting the pink blood to the left atrium to the rest of the body. So this is very important. Anyway, to make it simple, streaming in nature, in oceans, what happens is very, very important for our body and ductus venosus. So in this slide though, we'll try to see in different conditions, many of the blood vessels around the heart or in other parts of the body may get abnormal in different conditions. So this was our, okay. So this is our normal umbilical vein, and this one we started seeing is the A-wave flow reversal, and this one is that further A reversal. So this is one of the umbilical venous abnormality now. We are showing that umbilical vein is normal. It starts showing some phasing changes, and when you see that, we see some A-wave flow reversal as well. So very quickly on the same way for the umbilical artery, this is the normal one. That's a very good diastolic flow. The diastolic flow is absent, and now diastolic flow is reversed. And same in the circulocutaneous, back again in the middle cerebral artery, and we see this is normal flow. But this time it is other way around. We find the diastolic flow is very high. So I will stop now. As I mentioned, we have several things to talk. The whole vital intervention and those things we'll leave it. I think in this short time it is very difficult to go through. But if there are any other questions on whatever we have said or what we haven't said, but you possibly were thinking or hoping we'll touch, I'm more than happy to take a couple of minutes before our next speaker comes, and we'll hear more about the 4 chambers and in more details of that. But actually, why don't I go to the very last of my slide? It will make me long. Just to show you, you can email me. Actually, my email is there. Why don't you do that? That is the best thing to do. And I'll be more than happy to take answer if we do not have enough time to answer your questions. I think that's the best thing to do. Okay, so let's stop now. So anything else? Sorry, any other questions or answers? I think but please feel free to ask any other questions or anything else you have now. Are you okay now? Okay, I think we'll stop.
Thank you so much, sir. It was very informational. We are all delighted to be here today. This was very, I don't have words because it was very, very informative. Now I would request Principal Sir to please come up on the stage and felicitate our guest, our first speaker, Dr. Mandal. Please applaud, guys. Thank you so much, sir. Thank you so much, ma'am. Now we move on to our next speaker, and I invite my partner Aditya to enlighten us.
The second session is on 4-chamber cardiac anomalies by Dr. Rashmi Singh, consultant, Health Scan Varanasi. Dr. Rashmi Singh is co-founder and consultant radiologist, Health Scan Diagnostics Private Limited, Varanasi. She has done her UG from AIMS New Delhi and MD Radio Diagnosis from PGIMR Chandigarh. She did her residency of 3 years at AIMS, New Delhi. She has done her fellowship in OBS USG from Mediscan, Chennai. She aims at bringing a paradigm shift in fetal medicine in the city of Varanasi. Let's have a round of applause for her.
कौन सा ये दिख रहा था अब ठीक है ना
Very good evening, everyone, and I would like to thank Breaking Up and Teams for giving me the opportunity to speak on this topic of cardiac chamber. And I would like to thank Tapas sir for a wonderful excellent talk, and that his talk had made me my talk easier because he has explained a lot of things already, and some of them this will be a repetitions of sir's talk only. So before proceeding, sir has already talked about why we are worried about the cardiac anomalies in fetus, because we need to optimize their delivery. It's not about the diagnosis, it's about the caring about the fetus, because if we know about the cardiac abnormalities which can be corrected post-natally, we can suggest the delivery at a place, at a tertiary center where they have the facility for the surgery, ICUs and everything. Because transferring a neonates is much complex than transferring them in ABU. So that is whole in why we are so much stressing about the fetal echo and cardiac development. So sir has already talked about the place that we in a cardiac chambers while echo we scan. So we start from the fourth chamber, from the base of the cardiac. So this is the fourth chamber view. We again move upward, becomes the outflow tracts, which is the left ventricular outflow tract and right ventricular outflow tract, then followed by the 3-vessel and 3-vessel tracheum. This is the 5 basic view which we acquire by our fetal echo. And what I will talk about is the 4-chamber abnormalities. So none of the echo is complete without situs. So we first determine the situs, whether laterality is normal situs or any there of situs ambiguous or inversus like that. So in the 4th chamber, what you need to do is to identify this structure. So 4th chamber we can acquire by 3 techniques. Either it can be a apical view, or it can be in a basal view, or a lateral view. So basal view, in apical view we insolate our transducer from front to the back. So your transducer will be at the anterior chest wall of the fetus, and then this kind of picture that we will acquire. In lateral view, our transducer is on the lateral side of the chest wall, and then we acquire the 4th chamber. In basal, our probe is more of like from going from posterior or laterally to the fetal side. So basal view we often tend to acquire in 3rd trimester, because fetal position is not often such that we can acquire a apical view in 3rd trimester. Lateral view we often acquire when we need to see the integrity of the interventricular septum, because in apical view that I will discuss, we sometimes falsely get the echo dropout, which we need to confirm it on the lateral view. So in the 4th chamber view, what all the structures you need to see. So sir has, I think it must have already been discussed. So we need to first of all identify the chambers, what all the chambers are there. So we identify the left atrium. In left atrium there are the pulmonary veins which drains within the left atrium. So this is the left atrium. Left ventricle, you can see here, this is the left ventricle and right ventricle. Left ventricle apex is smooth and the wall is also smooth. In the right ventricle, we identify by the presence of this is the moderator band. So with this, we identify this is the right ventricle and this is the right atrium in which the SPC will drain. This is the flap of the foramen which this is the flap which is opening from the opening within the left atrium. So this has to be open within the left atrium. We need to then look at the valves. So this is the valve. This is the mitral valve and tricuspid valve. What you need to see here is that the tricuspid valve, it is inserted a little bit inferior. So they are not at the same level, what we call it as an offset. So offset we need to look for. Apart from that, looking into the cardiac structure, we need to see if the contractility, how it is contracting, is there any problems within the contractility or function, then we need to see the wall of the cardiac chambers, whether it's normal or it is thick, the endocardial lining, whether it is echogenic or not. Then we little bit amount of fluid, it can be present around the pericardium. Up to we consider it as a normal. Especially sometimes we can see fluid more across the ventricle wall, like 2 mm, 3 mm. In this time of end diastole, which is normal physiological fluid, you should not report it as a pericardial effusion. Then you should see that we consider this, divide the middle thorax in 3 parts. So 1/3 is occupied by one side of the lung, the other 1/3 is occupied by the other lung, and in the center is the heart. So if we divide in 1/3, 1/3, it has to be like 1/3, 1/3 part is occupied by these thoracic structures. And if we draw a line from anterior midline to the posterior midline, then 1/3 of the heart is on the right side and 2/3 of the heart is on the left side. So this appearance has to be maintained, because if we have information, then we can suggest there is some pathology or not. Then we look at the cardiac apex. For apex, we need to draw a line from anterior to the posterior and along the interventricular septum. And this angle, it is nearly 45 plus minus 20 degree. This is the range. In that range, if there is any deviation in the cardiac axis, then this gives us a clue to the cardiac abnormality. Apart from that, we need to look at the fetal rate, cardiac, how it is contracting, even while in the, just have an eyeballing kind of appearance, like you should just put the cine and see how the cardiac flow chamber is contracting and how it is functioning, apart from visualizing these important structure. And you should not forget about the cardiac space. What we see one major vessel. This is the descending aorta. If you are seeing few other anechoic structure, this would be an esophagus, or if it's transiently present, or it could be an azygous or hemiazygous vein in cases of the interrupted IVC, or this could be a vertical vein or connecting vein in cases of the DAVDC. So one structure you need to see in rectocardiac space. If you are seeing more structure, then you should suspect some cardiac abnormalities. And you should put a color Doppler across this inflows to see whether there is any regurgitated flow or not. And you can put a Doppler also to get the E and A wave of the opening of the mitral valves. Now, this is the checklist for the chambers, and you also should look for the chamber symmetry. So two ventricles are almost similar size. Little bit of asymmetry is acceptable in third trimester, but as case shown by sir of coaptation of aorta, if there is any chamber asymmetry significant, there are jet scores available for that. For that, you need to measure the biometry. We can take a measurement of the width of the at the time of systole in the mid part, and there are available jet score for corresponding gestational age. If there is any asymmetry, then we look for the causes of the asymmetry. So this is the checklist for the 4 chamber, what you all you need. So you can go through it or take a picture of that. This is a video. we should put a colored doctor to see if there is any regurgitation or not. Okay. So, I will discuss about the cases to show the food chamber abnormality, how you are going to assess. So, what is the abnormality in this food chamber? What is things you are seeing? What is abnormal? Any volunteer? So, as I told you, in the four chamber view, heart should be, where is the cardiac location? Where it should be located? Where the heart should be located in the thorax? Left side, it is on the left side only, but exactly on the left side, where it should be? 2/3 it should be on the left side, 1/3 it should be on the right side. But what are you seeing in this case? It is entirely on the left side. So this was the fetal left side, this was the right side. So if heart is pushed to one side, why it could be? What could be the cause for shifting of heart to the other side? Think logically. Either there could be any lesion within the thorax or anything which has herniated from the abdomen into the thorax. So thoracic lesions, what could be the thoracic lesions? Mass like effects which has linked to the deviation of the heart to the other side. So, what are the common fetal chest masses or lesions that lead to the deviation of the shifting of the heart to the other side? Any volunteer? So, common thoracic lesions are the CPAM or sequestration. But in this case, it is not. What we are seeing here is this anechoic structure. So anechoic structure is what? This is the stomach. So fetal stomach has come in the abdomen, thorax. So what could be the cause? What is this condition? So this is a congenital diaphragmatic hernia which has led to the levo position of the heart. But otherwise it is normal. So this is how you are going to assess the first where the fetal heart is located. This will give you the clue what could be the cause for that. So what we are seeing here is that this is the stomach which is seen in the thorax. The bowel are also herniated. So there is a left-sided diaphragmatic hernia which has pushed the stomach towards the right side. So there is a juxtaposition of the chambers, but otherwise cardiac chamber was normal. In this case, additionally, what we saw was apparent right subclavian artery. So this is the trachea. Normally, this is the subclavian artery. It courses anterior to the trachea, but in this case, it is coursing posterior to the trachea. So along with the CTs, there was associated right subclavian artery. These are the videos. I don't know why this video is not being played in this system. In the case 2, now we'll discuss about the case 2. So what are you seeing here? This is the fourth chamber. So what is the abnormality in the fourth chamber? At this level, the walls are closed. In this image, the valve is open. So one valve is opening, other valve is not opening. So when we are assessing the cardiac chambers, we should see that both valves are opening and they are located at normal position. They are maintaining the offset. When we are seeing putting the color dominant, there is flow across one valve only. It is not, there is no flow across this valve. So what does this suggest? So this is the chamber which is situated closer to the spine, is the left side of the cardiac chamber. So this is the right side of the cardiac chamber. So right side it is not opening. So this is a case of, so what is this condition? Yes, so this is a tricuspid atresia. So in the fourth chamber, you need to see the blood flow across the both valves. So in this case also there was associated VST, large VST, outflow were normal, and there was additional vein which was seen. So this was the left side, so pulmonary artery was very small, but there is an additional vein. This is the persistent left SVC. Pulmonary artery were very small. There was associated pulmonary atresia component. There was a left SVC. So there were abnormalities on the three vessels as well. And when we did the ductus, so there was a flow reversal in the ductus. So this was a case of tricuspid atresia with PST with persistent left SVC and reversal flow in the ductus because of increased pressure on the right side of the system. Now we'll discuss in case 3. So in this case, the sinus was normal, patient fetus was cephalic, so cephalic it was a normal sinus. So in the fourth chamber again what you are seeing here. So this is the left side of the fetus, this is the left and this is the right. So what you are seeing here, it's a case which is similar to the earlier case which I have discussed. So there is flow across only one valve, there is no flow across this valve. So this chamber is the left chamber. So there is, in contrary to the tricuspid atresia, here what is it? Mitral atresia. So what we are seeing here, as sir told, we should be normal condition, we should see similar flow, but here there is reversal of flow in the left side of the aortic arch. So right aortic arch, it shows the reversal of flow. So this is a case of a hypoplastic left heart which we have diagnosed because there is reversal of flow in the transverse aortic arch which has occurred secondary to mitral atresia. Now we'll discuss the case 4. So again this case is similar to the earlier case. So there is flow across one valve, but here there were additional abnormality in the outflow tract. So this is the left chamber, so right chamber. So right chamber there is a flow, but left side there is no flow, so there is a mitral atresia. But what we saw additionally was there was a outflow tract abnormality. So this is the aorta. So there is overriding of aorta. You can see one chamber, another chamber, it is committed, so and it is enlarged. There was pulmonary artery, it was arising from this trunk only. So this is a common arterial trunk, type 1, as we can see this pulmonary artery is arising from here. And so this case is associated, apart from the fourth chamber abnormality, there were outflow tract abnormalities. So far we have discussed about the mitral valve, tricuspid valve abnormalities and heart position within the thorax. This case 5, what you are seeing is very easy case. So it's the fourth chamber view. So what in the fourth chamber, as I told you, you need to see this intact septum. So interventricular septum, and this is the crux. Crux is formed by this is the cross sign what we see, and we need to see the septum drive out. So in this case, what you are seeing here, what kind of defect is here? So it's a muscular PST. It's a muscular PST which is in the apical region, predominantly in the apical region. So in the fourth chamber, we should see the intact interventricular septum as well as the crux. Case 6. So what is abnormality in this fourth chamber? It's a spottle. You can see a normal fourth chamber here. Apart from, you can ignore this defect. Apart from that, you can see the rest of the fourth chamber. Now you can see in this case what is abnormality here. So as I told, this is the mitral valve and tricuspid valve. It should not be that much apically displaced. So tricuspid valve here it is apically displaced, and there is a lot of regurgitation through across it. So it's an Epstein anomaly. Right? These videos are not playing at this was already discussed by the sir. So this is also, we should see the valves with the intact crux here. But here what we are seeing, the crux is not intact, there is a common AB valve. So it's an ABSD, and when you put a color flow across it, there is single flow inflow. So this is a case of ABSD. You can see here this crux is not formed, this dot sign he was talking about, and there is a linear insertion of the valves. Their offset is lost. So this is an ABSD, and there was other cardiac associated anomaly. So this was a DORB, that is why we are seeing this vessels on 3 vessel B apart from 3 vessels. So it was a DORB. The aorta as well as pulmonary artery both were arising from the right ventricle, and they are parallelly oriented here. This is a parallel oriented. So this is pulmonary artery, aorta. So this is a parallel configuration. So normally outflow tract they cross, pulmonary artery and aorta they cross each other, but there is a parallel orientation in this case itself. And both major vessels are arising from the right ventricle. So it's a DORB. So what is abnormality in this case? It's a 4-chamber. So this is left atrium, left ventricle, right atrium, right ventricle. What you are seeing here? So we should assess the chamber symmetry, right? So one chamber, if you see here, the width of this chamber is bigger as compared to this chamber. This is a second trimester, not a third trimester fetus. So in second trimester, we do not expect this much of chamber asymmetry. When we saw the 3 vessel, this is arch view. So what you are seeing here, what is abnormality in this arch? So this is aortic arch, transverse aortic arch. This is the ductal arch. Ductal arch to be too big, or this one is small. Either this would be a scenario. So in this case, what we are seeing here is the chamber asymmetry. So left side of chamber is smaller. So we should expect that this is smaller in size rather than considering this as bigger. So in this case, we calculated the Z score also. So there was a severe narrowing of the aortic arch. So this is the aortic arch. So it's not arising more and here if there were vessels which are arising from it. So it's confirmed that it's an aortic arch. So 10 vessels are arising. So as case showed by sir, there were a coarctation, there was a narrowing, but in this case narrowing is not there. The entire arch is narrow. So what we call it as tubular aortic hypoplasia. So it's a case of a tubular aortic arch hypoplasia rather than a coarctation. It has a bad prognosis. This needs to be delivered at a center where they have a facility for its management. So we need this case, it has many findings. In this case, I wanted to show you that you should document the pulmonary veins opening within the left atrium. At least you should document 2 pulmonary veins, because we do not want TAPDC or TAPDC to be missed. At least if it's PAPDC, the fetus can survive. But TAPDC, fetus is not going to survive. It's a cyanotic heart disease. It needs to be delivered at a places where it can be managed. So that case, we do somehow it's not plain. That case was a complex cardiac anomaly case. But you should document at least these 2 pulmonary veins opening in the left atrium. You can easily document. You can put a color Doppler also, but color Doppler sometimes we mistake. But use a gray scale to document that these 2 pulmonary veins are draining within the right atrium, left atrium, because this will rule out the TAPDC. So just to summarize that, when you are looking at the 4 chambers, you just do not have to store the images. You need to see in detail where it is located within the thorax, where is the cardiac axis, all the chambers are whether symmetrical, or there is any this concordance is there or not. So left atrium has to be connected with the left ventricle, right atrium with the right ventricle. Then we should look at the flap of the foramen mobile, whether it's opening in the left side or right side. We need to see the integrity of the interventricular septum. Then we should look at the valves, whether the offset is maintained, whether it's opening properly or not, whether there is any regurgitation is associated or not, whether it is. Then we should look at the pulmonary veins, then area behind the heart, then presence of any fluid within the pericardium, then any masses within the thorax, and fetal cardiac heart rate, rhythm, and contractility. At least with this, we can rule out major of the fourth chamber abnormalities. And many of the abnormalities like TGA and other outflow tract abnormality, we might not see any fourth chamber abnormality. Fourth chambers view might be normal in that case. So if a normal fourth chamber is there, that does not mean that the fetus is not having any cardiac anomaly. You should acquire all the recommended planes for while performing the fetal echo, and with this you can rule out at least detect major cardiac anomaly which needs the immediate resuscitation. Thank you so much for the patience listening. With this, I conclude my talk, and if there are any questions, I can take those questions.
Thank you so much, ma'am. I would request Neelam ma'am to please felicitate Dr. Rashmi Singh. Thank you, ma'am, for this wonderful session. The next session is on cardiac CT. The speaker is Dr. Akshat Agarwal from Akshat Diagnostics, Varanasi. Dr. Akshat Agarwal is an emerging academic radiologist with strong multi-institutional training and growing international recognition. Trained at CMC Ludhiana, KIMS, Sir Ganga Ram Hospital, and Rajiv Gandhi Cancer Institute, he has extensive experience in oncologic, cardiothoracic, emergency, and fetal imaging. He has presented over 30 scientific works at major global radiology meetings, ECR, AOCR, KCR, WCER, SCR, and published across leading index journals. His research spans thoracic and cardiac CT, neuroimaging, fetal ultrasound, and image-guided interventions. He also serves as a peer reviewer for RSNA. With expertise in multimodality imaging and certification in cardiac CT and interventional ultrasound, he has earned distinctions including the KCR Travel Grant and ECR's Invest in the Youth Award. Currently, as Director and Consultant at Akshat Diagnostics Varanasi, he focuses on protocol-driven cardiac oncologic and fetal imaging while actively contributing to education and research. We welcome sir with a huge round of applause.
Good evening to all the respected seniors, colleagues and juniors. So now we'll be talking after all the heavy exercises, a very light topic, cardiac CTs. This will be a very simple talk, very basic, very essential thing. So I can see we have MBBS, we have some of the faculty members. I guess let's make it a little interactive section. So everyone knows about the heart. Everyone has a heart, everyone has a beating heart. Okay, so can anyone tell me what are the basic anatomy of the heart? How many chambers do we have? Okay, so what are the names of the four chambers? Two atria, two ventricle, right, left. Full stop, done. Full stop, now you know the cardiac CT. You don't need to do anything else. So, heart supplies the body. What supplies the heart? How many coronary vessels are there? Can anyone name them? Sorry, can I just stand up and be a little loud? Okay, perfect. So you are now, sorry, you are MBBS, you are done. You can go home. You know everything. So, what is the problem with the coronaries? What if it stops? What if it stops supplying blood to the heart? Sorry? Heart failure. So, does anyone has a different opinion? Myocardial? Okay. What does myocardial function mean? Anyone can stand up and just say loud. I'm very short of hearing. मेरा बुढ़ापा भी से आ चुका है. So, कोई Myocardial ischemia. Myocardium is the muscle that beats the heart. Ischemia. Oxygen is not going there. The tissue is dead. Simple. What does the coronary do to supply myocardial, to prevent myocardial ischemia? It supplies oxygen to the muscles of the heart. Okay, so let's go. Now we keep the basics still here. Four vessels, four chambers, three vessels supplying the heart to keep the oxygen pumping to all of the body. Okay. So you knew the anatomy. Four chambers, right, left. We had extensive talks about this. There are surfaces, there are right atrium, right ventricle, left atrium, left ventricle. What forms what? Left ventricle forms a diaphragmatic surface, interior is formed by the right ventricle, left atrium goes somewhere else. Okay. So we talked about the coronary arteries. We have a right coronary artery, we had a left coronary artery, left anterior descending, left circumflex. Starting on the slides down, if you don't know. Then right coronary. Why is right coronary important? Does anyone, now coming to the difficult part, does anyone know what does the right coronary artery supplies? So, what is the most important structure in the right atrium? And AV node. SA node, AV node. What does it do? Makes the pace of the heart. So basically natural pacemakers. So right coronary supplies to the SA node, AV node, most of the right atrium, most of the right ventricle, and goes back. We'll see that how it travels. What does the left coronary supply? Right coronary supplies right, left coronary supplies left. Easy. So left coronary has two vessels, left anterior descending and left circumflex. Why is left circumflex important? I cannot. Okay, so what is dominance? Major part, okay. A little better defined version. How do you define the dominance? Which part of the heart? Posterior? Posterior interventricular septum is supplied by the posterior descending artery. Posterior descending artery decides the dominance of the heart. Right dominance, left dominance, co-dominance, and there's one fourth term which I guess they are not in the MBBS textbook, super dominance. So right dominance means there are two blood vessels, posterior descending artery, posterior lateral branches. It supplies most of the posterior of the left ventricle. Now if you have a right dominant heart, right coronary is supplying the posterior descending and the posterior lateral branches. If you have a left dominant heart, left circumflex is supplying. If you have a co-dominant heart system, right supplies posterior descending artery, left supplies posterior lateral branch. Posterior descending artery can never be supplied by two simultaneous vessels at one go unless there is a collateral formation. Now, what is a superdominant? So, superdominant is when a right dominant heart supplies posterior descending, posterior lateral branch, and it courses anteriorly from the left side and covers circumflex territory. So, we have a left circumflex vessels which is hypoplastic in a right dominant heart, and the right coronary artery supplies areas of the left circumflex. Easy. Right, left, non-dominant, co-dominant, superdominant. So in CT, we have easy images, you get everything. There is no 2D, 3D, 4D. So these are the 3D images, these are the 2D images. You can move it in any direction you want. Axial, coronal, sagittal, obliques, 360 degree, everything you can do, whatever you like to do. So these are the left main coronary going to the left anterior descending, the branches of the left anterior descending. So the vessel you see here turning backside is the left circumflex vessel. The artery which is going towards the posterior side from the right is the right coronary. So you see whatever you think. And then again, if you see and you're clear what you have seen, it's easy to make answers, it's easy to know the concepts, it's easy everywhere. Temporal bone, I guess everyone would have completed. So temporal bone में अभी तक कुछ concept clear हुआ? Floor, middle, medial, lateral. It was very tough for me. Middle, medial wall is this, anterior wall is this. So, but when we see it, it gets very easy. You don't have to be tukka marne wala काम. Right coronary, right side, anterior descending. It's showing anteriorly and descending. Posterior, posterior descending, going posteriorly and descending. Simple. So, coming left coronary artery, we have it arises from the left sinus, gives branch to the left anterior descending, left circumflex. There can be a possibility of a third branch, the ramus intermedius. Ramus is a branch, intermedius in between the left anterior descending and the left circumflex branch. So that way, ramus, left main coronary can trifurcate into three vessels. Quite common, 10 to 15% of the cases can have the trifurcation. So left circumflex, we just talked about a sinoatrial vessel. So right coronary supplies to the sinoatrial node in 60% cases. The sinoatrial node can be supplied in up to 40% of the cases by the left circumflex artery. Why is it important? Because if there is a blockage in the left main or the left circumflex, you will think the sinoatrial node might be saved, but it is not saved. It can go, the ischemia can involve the sinoatrial node even in a left side blockage also. Now we were talking about the dominance. Why was dominance important? We decided right dominance, left dominance, co-dominance, everything. But why is it important? It's not a fancy term, nothing special. Why do we have to learn in anatomy, cardiology and everything? Anyone? Even the PGs are allowed. PGs should be special. Now, PGs are here, right? Because now it would be the third time they would have heard about this thing.
So there is mostly right dominance which is common. So if the right is blocked, then there is no supply to the posterior interventricular septum.
So if the left is blocked, there is no supply to the posterior interventricular septum again if there is a left dominant heart. How is it important? You are not concerned about the anterior heart, you are concerned about the posterior heart only. If the right is blocked, the anterior side of the right atrium and right ventricle is also gone. So why a posterior descending artery decides the dominance of the whole heart. Why not the anterior, left anterior descending, or a septal branch, or a sinoatrial branch, or an AV branch, or any other branch? Okay. So the left main gives branches to left anterior descending, left circumflex. Left anterior descending goes down, supplies the left ventricle, the interventricular septum, the free wall, and the nearly 85% of left ventricle. The posterior descending artery supplies the rest of the 15 to 20% of the left ventricle, the posterior aspect of the left ventricle. Now, if you have a right side blockage, the only posterior part of the heart, but left ventricle is gone. Your left is saved, your left heart is saved, left ventricle is saved, your heart keeps pumping on. Left ventricle gives rise to aorta. Aorta gives the whole oxygenated blood to the brain and every part of the body. Now, if there is a blockage in the left main or a left circumflex, and the dominance is a left dominance, that is left circumflex giving rise to the posterior descending artery. The left main will give rise to left anterior descending, anterior side of the heart is gone, posterior descending artery originating from the left circumflex, again originating from the left main. Left main blockage, anterior gone, posterior gone, your left heart stops working. Left ventricle stops working, you die immediately. Your clinician, your patient won't wait that there is a 3-vessel blockage. Simple. Yeah. Circumflex coronaries, we decided that arises from the left main, courses inferiorly, supplies lateral wall of the left ventricle, can give rise to sinoatrial node in 40% and mediate dominant in 10%. So there are numbers in medicine. You are not safe if you think that you took a bio and you are saved from maths. There is more maths in bio than in maths. Everything, kitna percentage, how much probability, everything has this. How will you remember how much percentage or which is more dominant? Right dominant, you know, more is more common. Easy way to remember it, right-handed people are more than left-handed people. Right-handedness is 70 to 80%, right dominance is 70 to 80%. So easy to remember. Coronary artery dominance, you all know now. Anomalies. So every part of the body, nothing is perfect. But an anomaly does not mean it has to die for. It has to be died for. An anomaly can be a benign anomaly, a malignant anomaly. A malignant anomaly does not mean tumor or cancers in the heart system. It just means that a malignant anomaly can cause a sudden cardiac death, arrhythmias, or can lead to a malfunction of the heart. A benign anomaly just means there will be no problem in the functioning of the heart. So it is a vessel. Like we used to learn in nerves and vessels, origin, course, termination. Coronaries have origin, course, and termination. Origin, we have anomalous origin, so right-sided, originating from right, left, originating from left. It was normal. Now right originating from left and left originating from right, that is anomalous. A left main can be absent, that is origin anomaly. Left anterior descending and left circumflex can originate directly from the aorta. A left circumflex or a left anterior descending arising from the right cusp or right coronary is anomalous. There is the 3 cusps in aorta: right coronary cusp, non-coronary cusp, and left coronary. Right is originating from right, left is left, non is nothing. Nothing is originating from non-coronary. If the right or the left are originating from the non-coronary cusp, again anomalous. Then we go to the course. So anomalies of the course can have a myocardial bridging and a duplication. There's a whole long list, but let's keep to the very basics. We have a single artery going towards some structure, normal. Now the artery divides into 2, partially or completely anomalous. So rather than a single right coronary artery, we have 2 right coronary arteries, that is anomalous. Myocardial bridging. What does myocardial bridging means? Normally, we'll show that later. Leave it for that. So then anomalies of termination. Coronary artery fistula, extracardiac termination. Coronary artery fistula. Normally the coronaries originate from the aorta, goes around the heart, supply the heart and just terminate. If they open into a structure which they are not supposed to open, that's extracardiac termination. That's coronary artery fistula. So coronary artery fistula can open into a right atrium, right ventricle, pulmonary artery, left atrium, anything can open. extracardiac termination is when the same thing happens but outside heart. We are not opening into right atrium ventricle or anything. We are opening into a pulmonary artery. We are opening into a extracardiac structure. Okay, so benign versus malignant, we dealt with that. Malignant can cause potential ischemia, arrhythmia, sudden cardiac death. So when we listen to the gym stories, a person 40-year-old, 45-year-old, 30-year-old taking all the creatinine and everything, has a huge proper build, died suddenly, went off to the gym, was doing treadmill, died off. That's sudden cardiac death. A good number of autopsies show that sudden cardiac death can be because of these anomalies. The malignant ones, not the benign ones. So the malignant ones, first of all, will include an interarterial course. Okay. So this is the normal course, right, left, non-coronary. Right goes to right, left goes to left. Coronary artery is here, aorta is here. Now all the anomalies, the right coronary giving rise to the right cusp, giving to the right coronary, but also to the left circumflex. Left anterior descending originating directly from the left coronary. But the course is benign because it is going retro-aortic, behind the aorta, not going in between the pulmonary artery or the aorta. Similarly, pre-pulmonic, a vessel going in front of the pulmonary artery, not in between the two arteries. Again, retro-aortic, main coronary going and getting branched to left anterior descending and left circumflex. Again the same. Now this you see a left anterior descending going in between the right coronary and the pulmonary artery. This a right coronary going originating from the left cusp going between the two arteries. So that is an interarterial course. So the last two are a malignant ones. Can anyone say why is it not a good situation to have?
When there is load on the heart, then it can be compressed between the two arteries. So that can lead to ischemia of the part to which it is supplied.
You are exercising, you have not built up a huge stamina, your aorta is pumping much amount of the heart, you are getting back a huge amount of blood back from the pulmonary artery. So both the vessels, they are elastic, they can dilate. When they are dilating, they are compressing the artery running in between. When they are compressing the artery running between them, they can cause transient problems or long ischemias. They can cause arrhythmias. They can cause sudden deaths. Okay, simple. So we were talking about the anomalous courses. These are the CT pictures. Right coronary originating from the left side. Right coronary originating just next to the left main coronary. This is a left anterior descending vessel originating from the trunk of the right coronary, going in between the interarterial course and supplying the left anterior descending direction. So we skipped one topic, that was myocardial bridging. So I just wanted to have a look about the picture rather than trying to explain the theory. So the heart, the coronary vessels, this is the cavity of the atrium or the ventricle. These are the muscles, these are the epicardium. The coronary arteries are epicardial vessels. They go not in the muscle of the heart. When they have to travel inside the muscle of the heart, that is called myocardial bridging. There is a vessel inside the myocardium and traveling. So the most common artery which gives rise to this myocardial bridging episode is the left anterior descending the middle course. But not a rule that no other artery can have this. Any artery in the heart can have this course. There are actually various types of things that we have to see. We were discussing this last time also. So, first of all, why is it a problem? A vessel can travel above the heart, inside the heart. Why is it a problem for us? Why so? Why? 10 मिनट के लिए 10 मिनट
So it will compress during the contraction of the heart.
Okay, so
Sir,
it is an artery, it is supposed to compress.
Yes, ma'am.
What's the problem?
Sir, it could lead to ischemia.
Of the
Vessel of the heart.
of the distal part of the supply.
Yes.
So if you are having a myocardial bridging in the middle course, the compression is causing no flow or reduced flow in the distal most parts, and that causes ischemia or non-functioning of the heart. So how do you see ischemia? How do you see ischemia in a radiology-oriented setup? Let's say the patient is saying we have a myocardial bridging. Sorry, the problem with CT from ultrasound is that ultrasound is a live image. We can see what is going on in real time. CT films once taken, we are not. I understand now. That is a major confusion because we also used to answer the same thing. So what happens? Most of you would have heard about perfusion, stroke, brain perfusion, everything. So what happens in perfusion? Most of us you might remember umbra penumbra, core infarct, penumbra, peri, ischemia. So something similar, not the exact thing, happens in heart as well. You have a vessel, it gets contracted, decreased flow, some tissue died off, some tissue viable, some tissue at the border of the dead and living tissue. So how do we see that? We do a perfusion scan. Perfusion scan and ischemia. We'll come to the later. It's advanced things. We'll come up to the later parts. So perfusion will tell you that this part is viable and the next part is non-viable, and then there's a borderline viability as well. So the viability or non-viability most of the time will tell you that there is a problem. A patient will come to you, heart problems क्या होंगे, breathlessness or a chest pain. Most likely no other third problem, cyanosis. Let's say कि most of the time cyanosis might have been dealt in fetal life. So we are not concerned about right now the fetal thing, we are going to the adult stuff. Vessel was there, it got contracted, now you took a CT scan, the vessel is lying comfortably because you take a CT scan in the relaxed stage. You don't want the patient to be having a 140 heartbeat. You cannot take in most of the scans, but yes, you don't want the patient to be very hyper and then take a CT scan. So when you take a CT, the vessels will be dilated, their myocardial bridging would be present, but you won't be able to see that there is a contraction. Was there a contraction or not? Myocardial bridging is not a deadly thing in itself. In most of the cases, it is an incidental finding. So how do we report this thing? The depth of the bridging, is it deep, is it superficial? Less than 2 millimeter, more than 2 millimeter. Superficial, deep. Then again, a myocardial bridge can be a complete or an incomplete. If it's surrounded on its 180 degree side, it is an incomplete myocardial bridging. If it's completely covered on 360 degrees, it's a complete myocardial bridging. Superficial, deep, we talked about. Then again, in systole or diastole. If you have a systolic phase, you will see that the contraction, if there is a contraction of the vessel of the coronary vessel, how much is the contraction? We see IVC in respiratory, inspiratory and expiratory phases. Similarly, we see in systolic and diastolic phases about the coronary in the myocardial bridging. If it is compressed, how much is it compressed? Then last step will be perfusion scan. Does that compression cause hemodynamic instability? If yes, then myocardial bridging is significant. If not, then we can leave it to the clinician and the patient to decide if to be done something or not. So coming about the coronary artery disease, we were talking about the stages. Not the stages. We were talking about the course. We know anatomy. We know physiology. We know the course. We know the termination. We know everything. Now, why is it important? We talked about that also. It supplies the heart. The heart supplies the body. So, what is the problem? Most of us might have actually started developing atheromas. Pathology stuff. Periatheroma, atherosclerosis, lipid pool, calcification, rupture. Earlier the stage, lesser the problems. Later the stage, more are the problems. So a calcified plaque, a low attenuation fatty plaque, and a mixed plaque. 3 words, pathology. Macrophages, lipid come in, followed by macrophages. Macrophages settle up, calcification develop, surrounded by a fibrous gap, a rupture happens, person dead. Simple staging. So what is the problem in India? About 0.8 to 26 per thousand of people have a coronary heart disease, and these are Indian figures, no US, no Europe figures. Now we have a problem with the non-flow limiting unstable plaque. If you understand this much, the whole of the coronary thing is done. Non-flow limiting. If a flow is limited, the person will come with myocardial ischemia, he'll have a sharp shooting pain, he will go straight to the cardiologist or CTK surgeon, he'll have the excruciating pain, straight stenting or something will be done for that patient. Now we are not concerned about those patients, they will either die or get treated. We are treating the patients who are in between. So non-flow limiting. If you have a pipe, 100% of thing can flow, less than 25, half of the vessel can get clogged, a little more than half, more than 3/4 or more, most of it. Remember these words. Fine. It's easy to categorize less than 25, 25 to 50% blockage, 50 to 70, 70 to 99, 100% occlusion. Okay. Then non-flow limiting we understood, unstable plaque. Plaque, we talked about what is a plaque. Now unstable. Stable plaques are plaques which we are not too much worried about because they won't rupture, they won't give rise to embolus, they won't give rise to more plaques, they won't give rise to inflammatory reactions. They are just sitting there. They are incidentally found out. We don't need to care about them. Unstable plaques are fatty plaques, fissuric plaques, ruptured plaques, fine. Plaques which are going to create problems in the vessels. Now, what happens in an Indian scenario? The patient comes in with excruciating pain. First, what are we going to do? Any MBBS student takes. You have a pain in your epigastric or chest region. What are you going to do? कोई भी ego मत बोलना, ego गलत आंसर है. Cardiac markers. Have you ever experienced chest or epigastric pain? Have you gotten your cardiac markers done till now? So why for the patients are not so urgent? कोई भी ECG. Okay. Then what do you find with ECG? A 20-year-old or 30-year-old person coming, you are getting ECG done. Fine. Then investigation you want to get done other than cardiac markers? No clinicals going on. Okay. Sorry, someone said something. Physical examination and history. First things. पेन हो रहा है, कब से है, कहाँ है, क्यों है, कितने दिन से है, कचौड़ी खा के तो नहीं बैठे हो. Your acid peptic diseases are much more common than heart attacks even now. So get a history, then go for cardiac markers, ECGs, X-rays and everything. So even now, most common investigation to be ruled out is the chest X-ray. Okay. So this was the pathology which we were dealing about. Macrophage foam cells, small pools, core of extracellular lipid, calcium starts depositing in this stage when a fibrous thickening is happening, and then a plaque or a hematoma forms. These are the complicated plaques. So imaging modality wise, except from the cardiac markers and every blood investigation that you want to do, the first thing goes for the radiography. Radiography is a basic chest X-rays, easily available, everywhere available, anyone can read it. Less radiation, followed by echocardiography, nuclear medicine, CT, MR, angiography, huge list. So chest X-ray, what information does it get? If you have a cardiomyopathy, if you don't have a cardiomyopathy, do you have anything in your lung? But pulmonary TB is more common than a heart attack. A pleural effusion is more common than a heart attack. Do you have any other epigastric problems which might be seen? A perforation, free air under the diaphragm. These are more painful. But the problem still happens that most of the things are not delineated on a chest X-ray. Then we go for a, let's the patient says we are a 45 or 50-year-old male. The patient says I'm having a huge chest pain, recurrent chest pain. My family had a history of cardiac problems. We go for echocardiography. Echocardiography is the best thing till 5 years back for intracardiac abnormalities. Hemodynamic information, it's very good. Now MR is surpassing the echocardiography in hemodynamic information as well. The problem with echocardiography is a basic ultrasound. It cannot penetrate air and bone. So sometimes the structures can be left off. It cannot diagnose very good for coronary abnormality. It cannot diagnose extra cardiac abnormalities. Coronary angiography. Coronary angiography can be of two types: cath-based, catheter-based interventional procedure, or a CT-based coronary angiography, which is a non-interventional procedure. The only intervention in the CT angiography is a venflon, which is attached to your arm. That's it. That is the only intervention being done there. So what happens in coronary angiography? You snake up a catheter via your femoral artery or a radial artery, go into your aorta, go back to the heart, select the catheterized vessel, right coronary, left main coronary, pushes in your contrast, and then see if there is a problem. If there is a blockage. The problem with the blockage is you see the intraluminal. Inside the lumen you can see there is a blockage, but can you see outside if there is some compression? No, you cannot see. Is the plaque a calcified plaque, a non-calcified plaque, a mixed type of plaque? You cannot see. And then, as with every imaging modalities, you are not prepared if you are going directly with the coronary angiography in a catheter-based study, because you don't know if the artery has a high takeoff, very anterior takeoff, it has anomalies because you just straight rush to it. Nuclear medicine, we have thallium studies and technically labeled baby scans, which are there for functional assessment. Very rarely done, very rarely found also. Then what matters with all this stuff? We want to know the ventricular size and the function, we want to know the cardiac structure and the masses, the pulmonary vein anatomy, myocardial perfusion, and information about the stenosis. If the coronary artery has stenosis, has the patient already undergone stenting and grafting, and if there are any evidences of restenosis in those stents and grafts. You put in a stent, 5 years down the line, the patient again. You put in a stent or a graft, but the patient says he's having pain again. You want to know if there is a restenosis, and you want to see if there is a restenosis, there is a collateral formation, you want to go in again, or you want to leave the patient because the pain might be of some other cause. So why cardiac CT? Cardiac CT has radiation more than chest X-rays, but less than catheter-based angiographies. Contrast is needed, nephrotoxic. You cannot use it every kidney failure patient. Has gating and motion problems, your heart is beating at 70 plus heart rate. Even if your lung is moving, it gets difficult. Is less found. You cannot get a cardiac CT in every CT scan. No, but the advantages. Non-invasive, you don't need to get a pre or post-op checkup done, you don't need a catheterization, you don't need the patient to be put in an ICU setup, you don't need 2 hours of the patient or might be 15-30 minutes of the patient. Less radiation dose still than catheter angiography, high spatial resolution, fast, 3D hemodynamic data is available. The ejection fraction stroke volume which we are getting with echocardiography and MRs is now possible with cardiac CTs as well. Then global assessment of the extra cardiac anatomy. So we know the cardiac anatomy, cardiac pathology and extra cardiac as well. So these are the images which we get: a left anterior descending, left circumflex, right coronary. We can turn and tilt them in every way we want. These are the 3D images where we can see the heart, the aortas arising, the arches, the pulmonary arteries, the collateral vessels. These are the images for the aortic valve. So we'll come to them again. So the clinical indications. Why and when we are doing it? In a health checkup scenario, you are just concerned that you are crossing 40-45 years of age, you might have a heart attack sometime, you might fall down. So let's get a cardiac CT angiography done. You know what is your status. You know if you are healthy, you are not healthy, if there are blockages or no blockages. What are the statuses? Do you want to start any anti-lipid, anti-platelet or any other drugs? Simple health checkups. If you have a zero calcium scoring and a clear coronary, a probability of dying from myocardial ischemia due to blockage of coronaries in next 5 is zero. You might die of heart failure, but you are not going to die of myocardial ischemia in next 5 years. Then suspected coronary artery disease in intermediate risk chest pain. Normal, we got covered in health checkup. If the patient has very high risk chest pain, the patient knows that it's definitely an MI, the patient already knows that he had a blockage, he's straight going for the intervention, he's not coming to you for a CT scan. Then equivocal stress test results. Stress tests, you might remember about a treadmill test which used to happen, I don't know if it's still happening. A treadmill test was a stress test. If stress was given to you because you are going to run and jog so that you stress out, and if you develop a chest pain, then they'll say it's a positive stress TMT test. So, but if there's an intermediate or equivocal stress test result, when you are not sure that, okay, the patient has chest pain, but does it look like a cardiac pain or not, you can get a cardiac CT. Evaluation of a coronary artery anomaly, we covered most of them. Suspected coronary artery aneurysms, post-bypass graft patency. You have a bypass, you had MI, you got a bypass graft done. Now you want to see if the arteries or the veins which were bypassed, which were grafted, are still working fine or not. Preoperative cardiac assessment in prior to non-cardiac surgery in select high-risk patients. Patient coming for gallbladder surgery, 70 plus years, anesthetist says, go back, we are not going to operate you because your heart might not be giving a good ejection fraction. Your heart might be weak. So even in a gallbladder, in a case as basic as a hernia, mesh hernioplasty, you can get a cardiac CT. We are doing that just to see that your heart is fine, so that you can proceed with the surgeries in a non-cardiac surgery. Then prior to a transcatheter valve, so TAVI, your aortic valve is not functioning, you go in from your aorta, reach the aortic valve, you plant a new bioprosthetic valve. But prior to that, since it's a very delicate procedure, you are not doing and deploying a TAVI procedure daily, you need to get exact measurements of 0.00 millimeters about the aortic annulus and the nearby structures so that you can get a graft designed specifically for that patient. It's not a foot size that, okay fine, 8 number का जूता है सबको आएगा. It's a heart size, varies with every patient. So how CTCA is CT coronary angiography. Okay, helps in daily patient management. It rules in or rules out coronary artery disease quickly. It is a triage for invasive angiography. It avoids unnecessary catheterization. I guess no one would like to lie on a OT table and get a catheterization. So why do we do it for our patients? If it can be skipped, let's skip it. It's as basic as our ultrasound abdomen or a CT abdomen. You want to see first how is your abdomen or that concerned organ functioning. You want to go in for polylithesis, you get an ultrasound. You want to go in for your pancreatic surgery, you get a CT abdomen. And why not for the heart? You get the same scans for your heart done. You see if your heart is fine, your coronaries are fine, you are prepared, how you are going in, what are you going to do, and then you go. First of all, and then again. We'll come to the staging in the later slides. Unnecessary catheterizations. What happens? You have an MI, you got proven that you had an MI, but every MI does not need a stenting or a grafting. You don't want that. If your vessels are blocked less than 50%, let's get a stent done. No one wants that. So if that can be managed with lifestyle modification or medicines, let's go into the CT, see if you need a catheterization done, and then proceed to the catheterization rather than just going in blindly. Plaque characterization assesses both calcified and non-calcified plaques and guides medical therapy. Advantages compared to the invasive coronary, non-invasive, no catheter insertion risk, no risk of arterial injury, so we are safe. Stress testing, exercise ECG and nuclear echo, we have direct visualization of the coronary anatomy and detects non-flow limiting plaques. These ones will keep popping in. Then compared to the coronary artery calcium score, which we are going to discuss now, it provides detailed and accurate function. So how does it help an interventional cardiologist? A cardiologist says we have a catheter, we know how to go in, we know how to put in a catheter, we know how to put in a graft. So why do I need it? We are not stealing their jobs, we are making their lives easier. Right? So we reduce the diagnostic catheterization. We'll say you just go and earn more money, you go in when the stents are needed. You don't go and just go in and come out. Yes, we are saving your time. You see more OPDs, you earn more money. Then choose catheters. Which catheter? There is not just single catheter, there are multiples of catheters, the angle of the catheter, the length of the catheter, the limit, the length of the balloon to be deployed, the length of the stents to be deployed, identify the graft anomalies, evaluate coronary lesions, and prepare for coronary intervention. So these are some of the papers which says why is CT angiography as good as a coronary invasive angiography. So invasive coronary angiography even today is a gold standard in a patient with MI. Gold standard for a, let's remember three words: invasive coronary angiography, gold standard, MI, proven MI patients, not for non-proven MI patients. Different papers, everyone seems the same. So let's see the PPVs and the negative. PPV is the positive predictive value, NPV is the negative predictive values. So positive means if I am saying a plaque is there, I might be, let's see this numbers 89, 92, so let's say 85%. So I might be right in 85% of the cases, in 15% of the cases I will be wrong. What happens with negative predictive value? So negative predictive value we have, if I say it is normal, then I will be true. That is negative predictive value. You see negative predictive value is much better, 99, 99, 98, 100, 199. So more than 95, let's say on an average. So if I say a coronary has an obstruction, I will be 85% correct. If I say a coronary does not has a lesion, I will be 100% correct. So you want me to be correct in a negative value. If I am saying you are safe, you want me to say that. If I am saying you are not safe, okay, we'll have to do something. Limitations, radiation exposure, contrast, allergy. This video is not going to work. Otherwise, I would have showed you how easy it is to get a cardiac CT done. Then planning, choosing the appropriate technology, technique, temporal resolution, acquisition. So acquisition can be ECG or non-ECG gated. We talked about ECG. We wanted to get an ECG done. Let's get it on a CT coronary angiography patient. So the heart is a mobile structure. More than 70 heartbeats. CT scanners are moving. The heart is moving too fast for anyone. The lungs, even for a simple lung CT, we ask the patient to hold their breath for 5 seconds. You cannot ask the patient to hold their heart for 5 seconds. So you need that ECG gating. ECG gating, what does happen? So P, Q, R, S, T. Everyone knows that part? Retrospective ECG, prospective ECG. Prospective is coming forwards, retrospective is going back. In a prospective ECG gating, what happens? We are doing the calculation and the radiation exposure when the patient is getting a scan in lifetime. You are seeing the ECGs, the machine is seeing the ECGs, you chose a prospective ECG gating. The machine shoots the exposures when there is a most stable time. If you see for an ECG, the most stable time is the RR interval. 70% of the duration, the most stable time, diastole phase, the vessels will be most dilated. Simple thing. Now retrospective ECG, you said that you told the machine that you shoot for the entire length, let's say 5-10 seconds for the heart, and then you go back and calculate every vessel. Some vessels might be obscured, some vessels might be dilated. You make out of different phases the vessels from whichever it is necessary. Okay. Processing, let the computer do it. Interpretation, let the radiologist do it. Calcium score, again, now this is an important thing. So we have multiple studies from Scotland, Europe, USA, Russia, everywhere. A calcium score gives you a risk stratification with prognostic value. Risk stratification, it is a screening test. It is not a diagnostic test. Like a chest X-ray, it is a screening test. It is not diagnostic. Similarly, calcium score is a risk stratification with prognostic value of 3 to 5 years, but gives no assessment of stenosis. As the name suggests, calcium score, you have this, show you this. So you have calcium, you see the white part around the vessel, you have white part, white part, white, everything. These are the increasing order of the plaques. Here a small plaque was there, a larger plaque, multiple plaques, the whole vessel is calcified. You see the score 100, 200, 400, 4400. The amount of calcium increases, the volume of calcium increases, the more probability of you getting a coronary artery disease increases. So, a coronary artery calcium score is a non-contrast scan. It is as equivalent to a chest screening, not an HRCT chest, a chest screening technique. It takes interpolations of the coronary arteries only, not the whole chest. Sees, checks out for the calcium. You have to find out the calcium in the 3 vessels. You mark them. The computer calculates the volume and the amount of calcium and gives you a coronary artery calcium score, which is scaled according to a Ganston scoring. Who needs a calcium score? In India, let's say everyone. We have a family member who might be having a coronary artery disease. Most of us are dyslipidemic, most of us are smoking, most of us have hypertension or diabetes. So everyone needs a coronary artery calcium score, mostly after 35. Western literature says 45. As in India, everything comes back to a little precursor. For India, 35. The plaque burden, P1 to P4, mild, moderate, severe, the score goes in increasing. The more the score, the more amount of drugs you have to eat. In 1 to 100, you might just get away with antiplatelets. When it goes more than 300, you will have to add antiplatelets as well. Now coming to the cataracts. So why did we study about the coronary artery diseases? In every subject, we have a staging here as well. Cataract stands for coronary artery disease reporting and data system. Earlier the scheming used to be on the scientist's name or some random person's name. Now we have everything according to the reporting and data structures. BIRADS, TIRADS, ORADS, LIRADS, everything is standardized. You don't need scientist's name to remember कि कौन सा scientist ने क्या किया था. You just need the reporting and data systems. Clear tables, no need to learn up also. Computer पे phone पे मिल जाते हैं. Easy structure 0, 1 to 24, 25 to 50, 50 to 70, 70 to 99, 100 non-diagnostic. We remember those numbers 1 to 5. 0 plain normal. 1 से 5 तक in the severity keeps on increasing. Minimal, mild, moderate, severe. 100% is total approach. There is a category involving N, non-diagnostic. When the image is either too shaky, too much calcium, the patient is jumping on and off, the contrast does not go, where you cannot say what is the cataract score, calcium score, or the how much is the blockage. So radiologists were smart. They decided that let's say हमें नहीं पता से non-diagnostic. It was the patient. It was the problem of the patient. So what was the goal? It did standardized reporting system, provides clear and consistent reports, improve communication. So let's say if I say cataracts to you, will also say cataracts to in any part of the world. I based on one thing, 0 to 50. You see further cardiac investigation, none. So if you are getting a cardiac cataracts too, that is 50 up to 50% of stenosis, you don't need to do anything with the patient. A lifestyle modification is as good as anything. Then 50 to 70% functional assessment is needed. More than 70%, you need to consider interventional cardiac assessments. You do a stenting, grafting, whatever you want. Then we have a cataracts for acute chest pain as well. This was a stable chest pain, this is an acute chest pain. We include troponin testing as well to categorize the patients. Now we do cataracts. Cataracts has modifiers as well. If the patient has a stent, a CABG done, a high risk plaque, and an exception. So we'll come around that. Features of a high risk plaque. So what we were talking about high risk plaque. If we have a stable plaque, we are not worried that much because the surgeons and the cardiologists can handle that well. If we have a high risk plaque, we need to tell that to the surgeon or the cardiologist so that they can go in with that mindset that we are going to have a problem. This plaque to be touched, not touched, what is the problem. So we have different criteria for that: spotty calcification, napkin ring, positive remodeling, low attenuation power. So these are all study oriented. People did a lot of studies to see if spotty calcification are high risk or not high risk. So they found these spotty calcifications were high risk. So for that you go to the papers. We don't have that much of liberty with the time. Modifiers, non-diagnostic high risk stent grafting. These are the graphs. Modifiers exception. What does exception mean? Exception means chest pain, not because of a coronary. Pulmonary embolism, dissections, any other cause than a coronary, a vasculitis, coronary artery fistula, an extrinsic coronary artery compression. Decreased size of lumen, but not because of the intrinsic atheroma. The cases, so here we can see a small plaque which is causing less than 25% of blockage. Rest of the artery clear. So here we labeled it as cataracts 1, P1. P1 because the calcium score came out to be some 4.3, less than 10, we are clear. In second case, we saw a little more amount of calcium, including 2 vessels. This is a right coronary, this is a left anterior descending, causing approximately 20 to 25% of stenosis. More amount of blockage, cataracts 2. More coronary artery calcium score, P2. Third case, more amount of blockage, 50 to 60%, cataracts 3. Cataracts 5, total blockage. We cannot see any contrast passing through this area. Contrast is found in the proximal part, distal part. We have calcium as well, but this area shows no contrast passage. These are the stent cases. So here you can see the 3D image that the stent is already there. Stent is there. These are the stent images. So you have to see in a stent case that there are no blockages in the normal vessels as well as in the stent segment. That we can see there was no black or white part. So the stent was clear. Then again, this is a stent where we can see there are actually, if you see like this, you will see that there is a one stent. But when you magnify it and you see properly, these are the stent struts that are ending. So we have actually 3 stents lined up. So the blockage might have been a long segment blockage. You found it. If you would not have done a CT beforehand, you would have gotten it fumbled up. You would have seen that there is a long segment blockage. You would have more time for the same things. Now we had 3 stents, all with no significant re-stenosis in the stent. This was a case where a left atrial myxoma was already present. So we can see the myxoma, and we can see that there is mild blockage in the left anterior descending vessel as well. So we talked about TAVI, where aortic wall was getting changed. So this is a patient who had, you can see these vessels, these are grafts. We can see there are grafted, there are 1, 2, 3, 4. At least 4 grafts are 1, 5 grafts are present, out of which 4 are venous grafts. One is a lima graft, that is a left internal mammary artery. Graft can be an arterial graft or a venous graft. A venous graft has a shorter lifespan, arterial grafts have a larger lifespan, if you choose the arteries properly. Okay. And plus lima and rima lie in the surgical field of a coronary artery bypass surgeries rather than a venous graft, which has to be taken out and dug out from GSV, great saphenous vein, or any other part, whichever is found possible. So this patient had grafting done already, and a biopresbytic valve was done, which is a TAVI. We can see the valve. No thrombosis was noted in this graft. So we need to check 3 things: native vessels properly functioning, graft vessels properly functioning, and TAVI no thrombosis present. Then this case had a typical thrombus in the left ventricle, had multiple grafts done. So for this patient, if you needed to have a cath lab and catheterization, the first thing would have been to stop the antiplatelet drugs, because you are going in with a intervention procedure. You cannot ask the patient to bleed out just to check if your grafts are working or not. But to stop the antiplatelets, the thrombus would have grown in size or might have embolized. So these cases are much better for CT scans because you see that the thrombus is there. You can check out the lumen patency for the grafts. Again, so this is a almost near occlusion of the proximal coronary vessel. If you can see, the right coronary origin is a acute takeoff. Like a normal coronary would have gone like straight, this side, straight. But this has a straight acute U course. Now, if you are not going prepared, you are going to have difficulty in selecting the catheters. You might not even have an optimum selection of catheters present at that time also. Again, near total blockage, you choose the catheter, you choose the length, you are prepared that how much length of the catheter stenting is to be done. You go in with the invasive catheterization, you see that almost near total occlusion is present, post catheter stenting, normal flow is preserved. So CT-FFR, CT perfusion. These are for the advanced studies. CT-FFR is fractional flow reserve. What does fractional flow reserve means? The non-invasive technique. We are already doing a CT coronary angiography. In that we see for the pressure and the flow in the vessels. It is used in a coronary artery stenosis ranging from 50 to 90%. That is a cataracts 3 or 4 or more. So cataracts 2, if proximal stenosis more than 40% with high risk plaque. The only situation in which cataracts 2 you will do a FFR. If it's a cataracts 3 and 4A, you are going to get a CT-FFR done. The only problem in India, it's a very high resource-based software which is patented to a US company. They charge 75,000 per case basis. But they give you the results in 7 days, a very good result. So these are the values, less than 0.7, more than 0.8 and borderline. So now you had this coronary, you had plaques.
So we're just trying something for the first time. Please sit down. Just trying something for the first time.
Thank you. Thank you so much, sir.
Audio.
We're trying something new today at Heritage. And before we move towards the end of our event, it's our honor to invite a distinguished guest to share her remarks. Dr. Shalini Sharma Modi, a proud graduate of AFMC, currently serving as the Chief of Cardiology at Henry Ford Hospital, West Bloomfield, Michigan. She is a board certified general in cardiology, echocardiography, and nuclear cardiology. She joins us here today all the way from Detroit. Ma'am, over to you for your expert comments. I think we'll take a little while, so some technical errors. After that, we immediately switch to Dr. Shalini ma'am, can you hear us? Can you please unmute yourself?
Give me the mic. Hi, Shalini. We were trying to unmute you. Till then, you can say hi to Pratap.
Hi, Shalini. Hi. Nice seeing you after a long time. Great.
Shalini, there's a request for the technical glitch that we're facing. Just delink and join again. Just delink and join again. Shalini, hello? Still not unmuted. So at least we are lucky to see you after maybe decades. Me, Shalini and Dr. Pratap, we are from FMC, the same batch. And we call the batch Z batch, A to Z, the last one of the grades. So really sorry. She came to support us because the principal wanted an international conference for the first time for Heritage, and this was at very short notice. I thank all the UG students who helped out with things, and there was no preparation at all. It was kind of an experiment. I hope the students have enjoyed it, gained something. So basically I told the first speaker also there are more UGs to simplify it. Dr. Akshat has also obliged simplifying things, and Dr. Rashmi also obliged simplifying things. Otherwise, next time we'll make it a more PG-centric event. So Shalini, just check out. Yeah. Just try unmuting yourself.
Yes, I think so.
Yeah, hi, we can hear you.
Yes? Can you hear me?
Yes, ma'am, we can hear you. Welcome,
Good evening,
ma'am.
everyone. Yes, good evening, everybody.
Good evening.
This is fantastic. I have thoroughly enjoyed and want to thank Dr. Akshat, who I believe is the presenter. It was a fabulous talk so far, what I heard, and it's very relevant as a cardiologist. And to all the students, the most important point is that you covered everything so far in fabulous detail. But I would say the most important thing that he stressed upon, whether you noticed it or not, was the emphasis on the history. Before you do anything, that good old bedside medicine, which I know this is radiology, but that history is very important, because only then will we start ordering tests. Otherwise, the whole thing becomes very expensive, right? So if we don't take a good history, we cannot categorize the patient as having stable angina, unstable angina, or is this a myocardial infarction in evolution? So that is very important, and then coupled with an ECG, remembering very, very well that a normal ECG doesn't mean anything at all. You could be having a circumflex ischemia going on until you do posterior leads. You're not going to see anything. So the history is gold. It's weighted and gold before anything is done. And then come the biomarkers, and then come the imaging. And I think all the points that were touched on in anatomy were spot on. Spending time about coronary anomalies, of course, the most important thing. And I think the students are very bright, because their answers for why alpaca is important, getting compressed between the pulmonary arteries, very, very relevant. More so in our younger folks, but also a common congenital abnormality that gets undiagnosed, and as you know, is the number one adult congenital is a bicuspid aortic valve, which people grow old don't know. But other than the valve, the association of an ascending aortic aneurysm with the bicuspid valve is very important, and you have the key to that because you can recognize it. So for me, even if I don't have a coronary CT, if I am seeing the patient in the clinic and I have a lung CT, I'm looking for coronary calcification, right? Because then, to the points that the speaker made, it helps me assess. And there is a clinical score that we use from AHA. Any one of you can go online and look at it. It's a PREVENT score. or even MESA, the whole database from which, coronary calcification across various ethnicities came back with risk stratification for the risk of coronary artery disease. Looking at that, all of that is very helpful in, it adds to the clinical weightage of what is the likelihood, right? After all, this is all using both, is the patient low risk, intermediate risk, or high risk? If they're high risk, they're coming with symptoms, obviously the gold standard, as the speaker mentioned, you go to an angiogram, but then if not, then all these other things can be done. So the CT for calcium, CT for aneurysm, CT for IV reflux, if there's contrast being given, is very important for pulmonary hypertension. We don't talk enough about pulmonary hypertension, but it does, it affects the RV, and it should not be neglected in reports. So also myocardial bridging and the anomalous, and then pericardial cysts sometimes will be commented on CT, which cannot be seen in echo, and they can be a manifestation of chest pain in an individual for which CT is required. The coronary cameral fistula, yes, coronary CTs can be seen when it's open, but actually even echo we have written case reports where echo with contrast showed these fistulas arising from the coronary opening directly into the LV. And then another thing in the emergency room which is done is a triple rule out for anybody coming in with that chest pain. So dissection gets excluded, PE gets excluded, and of course the coronary status. And then in terms of echo, for somebody who comes in with acute coronary syndrome, wall motion abnormality cannot read it, right? There is something known as the ischemic cascade, and the last thing that happens in that ischemic cascade, so number one is actually heterogeneity of flow that happens in the ischemic cascade, and that the advantage is nuclear imaging, right? Because that's what you're comparing is heterogeneity of flow. And then come the diastolic dysfunction, heterogeneity of flow, EKG changes, and then in the end wall motion. So if there's a patient who's being evaluated in the emergency room, coming in with chest pain and echo shows wall motion, that is, we don't need anything more. There is active ischemia going on at that time. Pericardial effusions, pericarditis. You have some degree of pericardial effusion that will help aid in the diagnosis of chest pain. Dissection we spoke about. There are parts of the aorta notoriously missed by transthoracic echo, but if there is AI and it's new onset aortic insufficiency, then that kind of clues us in. And then the other thing I wanted to comment upon was LV thrombus. Sometimes prior history of myocardial infarction, but now there's LV thrombus for which contrast is used. Or if there's apical regionality, that patient is set up for a LV thrombus. These can embolize, right? And the patient, it can embolize down the coronaries, or the patient can come in with a stroke. That patient can be very well served, and they, with an echocardiogram, they will have a manifestation of acute coronary syndrome. Similarly, endocarditis, not spoken enough about. Masses, they will have troponins because they're embolizing down their coronaries. They will manifest like that. And also atrial fibrillation. We don't look enough for it. It is sort of an aortic stenosis, and atrial fibrillation is the biggest epidemic in the US adult population. And they can have a thrombus in the left atrial appendage, which again, in CT can be seen, and that will also embolize stroke, renal, splenic infarcts, and all of that. Comment also on aortic stenosis and CT. We have various categories on judging where a patient is in the journey of aortic stenosis, and this is not to talk about aortic stenosis, but the amount of aortic valve calcification, pay attention to that when you're reading CTs. See, the more the calcification, more likely the stenosis, more severe the stenosis. And there is a paper in New England Journal by Rosenegg, was 2003. The amount of calcification also correlates with the progression of aortic stenosis as the patient gets older. So this is very important. The cutoff for women, if it's more than 1,200 in women, and if it's more than 2,000, then in men indicates severe aortic stenosis as well. And then I think there's a beautiful case of myxoma that the speaker showed. Then a few comments about SPECT. More than SPECT, I'm not sure if in India we're doing PET, and then now we are also doing fluperidase. The advantages are that we can actually exercise the patient, and whenever we look at data, so nuclear imaging maybe, and the newer angina guidelines that came out in 2024 talk about if there is a low risk NSTEMI, we actually can categorize non-STEMIs. STEMIs are going to the cath lab. High risk STEMIs and non-STEMIs also going to the cath lab, but if there's a low risk non-STEMI, we can use perfusion imaging to categorize them and avoid this risk of giving that contrast. So for that, PET is very helpful. If PET is not available, SPECT can be used. And here for PET, we do use rubidium, and fluperidase is new. And with rubidium, we're stuck. Because of the short half-life, you end up doing a pharmacologic agent like regadenoson or Lexiscan. And the disadvantage is that you cannot exercise the patient. You can do the same for exercise echo, exercise imaging with SPECT. So the advantage of the newer tracers, fluperidase, is that the patient can be exercised. Obesity is a big problem. You get great pictures with PET. And of course, for viability, I think Thailand is great because I think Thailand is used in India. But also for viability, PET is fabulous, using FDG for viability. And then cardiac MRI is also used for viability. Cardiac MRI is very helpful for cardiomyopathies. Amyloid, hypertrophic cardiomyopathy, you're looking for LGE, looking for scarring in cardiac MRI. And then the cardiomyopathies. And in terms of cardiomyopathies, whether it's non-ischemic, ischemic, right? The speaker spoke about how do you see ischemia. I'm talking this is infarction. And viability based on how much of the myocardium is infarcted, whether there are aneurysms, whether there is myocarditis, we did not even talk about that. Myocarditis will present, coronaries will be clean, but there will be evidence of mid-myocardial scarring, that is classic pathognomic for myocarditis, versus if it's ischemic in origin, there will be subendocardial scarring that will be seen. Additionally, the area of LGE also helps us to know whether this we're looking at amyloid, the LGE pattern, or sarcoidosis is another thing. With all these things are very helpful. Sarcoidosis, the typical presentation would be arrhythmias and heart blocks in a young patient coming in with AV block must think of sarcoidosis. Amyloid, the congenital, the hereditary kind of amyloid, seen more in the African American population because of genetic mutations. However, because of people living longer, there is a wild type, and those patients can be seen with amyloid. And if there is amyloid suspect, then in terms of radiology, P/P imaging is done to see whether they are TTR or not, whether it's AL amyloid, for which blood testing is done. And then lastly, talking about my realm of cardiac catheterization, we spoke about the causes of acute coronary syndrome. So coronary artery disease, the big chunk, and that's where all these other tests are done. And myocardial bridging, patients can also present with acute coronary syndrome. We said pericarditis is in the differential diagnosis of chest pain. It can be myopericarditis, where the proponents will be positive for the students who wanted to do biomarkers for a patient with chest pain. They can have myopericarditis, and done an echo, there's pericardial effusion, and then the classic ST, segment depression in the inferior leads, but AVR, ST elevation, that's pericarditis. Tumors, if they're seen, then of course, if they need intervention, they need CAS. But where else? There is functional testing of the coronaries. Coronary spasm can be induced in the lab, and we do it routinely. There is this whole entity we call MINOCA, MINOCA, myocardial infarction without obstructive coronary artery disease. Or there can also be stable disease causing without any obstruction. But the patient keeps coming back with chest pain, and we have to give those answers to our patients. So for that, acetylcholine is given in the lab to see if we are able to reduce spasm, classic, correlating subjectively with the patient's symptoms as well as EEG findings of ST changes and or also looking for endothelial dysfunction. So all these things, there's a lot in our armamentarium in this day and age to help our patients with coronary artery disease. And with that, I will conclude my remarks so that the rest of the wonderful program. I want to thank the organizers, Dr. Srivastav, to give me this wonderful opportunity to interact with you.
Thank you for the big amount of things we should actually talk about in the next sessions. We'll try to cover most of them for the next time. We actually had a huge population of the students who were either MBBS or just starting PG. So we tried to concise that in the basic and the most essential stuff so that they can cover and gather most of the information in the least amount of time possible. But definitely your comments are well appreciated and we'll try to cover all of them in the upcoming sessions. And we hope for your guidance in the future sessions as well. Now we'll just conclude with the PPT, 3-4 more sessions, 3-4 more PPTs. So we were talking about CDFFR. So we can see that the more amount of glue means more and better flow, better pressure gradient, better amount of blood flowing to the coronaries. The amount goes, when the color changes from green to the red, we are getting less and less pressure gradient. So we can see that the proximal arteries of the right coronaries are almost completely having a proper pressure gradient in the proximal 2/3 course and with a little bit of pressure for the distal 1/3. We can see that the left main coronary giving rise to the left circumflex and left anterior descending. The proximal vessels also have a green supply. So they have a decreased pressure gradient. So it does not mean if the contrast is flowing that everything is good. We need to go for fractional flow reserves in cataracts 3 and 4A because we know that there is a blockage, but is that blockage hemodynamically unstable, stable, going to affect the patient? That is also important. Structure, first thing is the structure, but the second thing is the functional results. Then CT perfusion, we were talking about perfusion defect, present, not present, borderline. Just focus on this and the last image. So this you can see that the normal perfusion of the vessel wall totally a little gray. The dark black structure shows the perfusion defect. So this is a